Hello everyone, welcome to Patho Excellence. In this lymph node cytology video series, today we are going to learn the polymorphous lymphoid cell pattern, which is one of the pattern of algorithm 3, which we have already discussed in previous video. So whenever we see this polymorphous lymphoid cell pattern in FNAC smear, the question is whether this lymph node is reactive or are we missing lymphoma? So, today we will decode the polymorphous lymphoid cell pattern, a pattern that usually suggests a benign reactive process but can sometimes hide serious pathology like lymphoma. So, by the end of this session, you will be able to confidently differentiate reactive from neoplastic pattern using simple high-yield cytologic clues. So, polymorphous cell pattern include mainly reactive hyperplasia, but there are different lesions which can give this polymorphous cell pattern. So, our learning objective is to master polymorphous lymphoid pattern, differentiate reactive versus lymphoma, how to apply ancillary test and avoid diagnostic pitfalls. So, by definition, the polymorphous lymphoid cell pattern include mixed population of lymphoid cells. There is different stages of maturation of lymphocytes. It reflects immune response and the prototype is reactive lymphoid hyperplasia. And in this pattern, the spectrum of disease include starting from reactive lymphoid hyperplasia, HIV, syphilis, toxoplasma, rheumatoid arthritis, Castleman, Kimura, dermatopathic and Sézary, Cat-Stage, follicular lymphoma and nodal marginal zone lymphoma. But if we divide histologically this pattern in three category like follicular and paracortical hyperplasia, which associated conditions with this type of reactive hyperplasia are here, and granulomatous lymphadenitis, where we can find mostly TB, fungal toxoplasma like infection, and another is sinusoidal expansion. So, whatever the pathology or whatever the histological finding like follicular and paracortical hyperplasia means the disease is affecting mainly follicle area as well as paracortical area, and there is hyperplasia of that particular region. And in sinusoidal expansion, the lesions are mostly sinus histiocytosis with massive lymphadenopathy, which is known as Rosai-Dauphin syndrome, and some lymphangiogram effect and Whipple's effect. So, these are the conditions we can divide either in the form of histologically this morphologically pattern, and in cytologically it is mainly the polymorphous pattern. So, as we have discussed, the reactive hyperplasia, it is a prototype and it is benign and reversible. Most common pattern, generally etiology is unknown in most cases, but 10% of cases are due to infection or drugs. Now, cytologically, as the name suggests, polymorphous means small lymphocytes, centrocytes, centroblasts, immunoblasts, plasma cells, histiocytes and tingible body macrophages, all are in one smear. So, this is polymorphous pattern. Now, what is the immunologic basis? So, follicular hyperplasia, it suggests B cell response to particular antigen, and plasma cells increase due to humoral immunity, and paracortical hyperplasia, which is due to T cell response, and in this particular hyperplasia there is predominantly immunoblastic proliferation, and we can find now increased number of immunoblasts, and all this pattern depends on antigen. Now, if inflammatory pattern is there, it is due to bacteria and fungi, immune mediated mainly due to viral and drugs, and for that we require clinical workup so that we can get clue to diagnosis of particular response. So let's see first the non-specific reactive lymphohyperplasia, which is prototype of this pattern, where the etiology is showing diverse causes, unknown etiology, and as the discussed, that 10% is due to either infection, drugs, or immune stimulation. Here the clinical features most commonly affected is children and adult population, rarely in elderly. And here the nodes are soft, small, oval and regional are mostly enlarged, and common sites in children are cervical and in inguinal region, which is common for reactive hypoplasia, and they generally resolve in 6 to 8 weeks. Now cytologically, if we see, we have to see a highly ideal lymphoid smear, which is in the form of having ovoid swelling with ovoid smearing with feathery edges. So whenever we see microscopy, we have to see the center portion of the smear, and we have to see ideal dispersed cell population to look for its pattern. So avoid this and where origin and end. So feathery as well as the origin portion we have to avoid, and always look in the center portion where the smears is properly spread. So generally this type of smears are highly cellular, having dispersed lymphoid cells, showing lymphohistiocytic aggregates, and there are numerous lymphoglandular bodies. So in previous lecture also we have discussed what is lymphocytic aggregate, which is nothing but the germinal center fragment composed of centrocytes, centroblasts, some dendritic cells, tingible body macrophages, small lymphocytes. These are the fragments in low power view, and here we can see tingible body macrophages, and these are the follicular dendritic cells. Best seen is at the low power view. In early stages, means 0 to 4 weeks, there is numerous centrocytes, small lymphocytes, variable number of centroblasts and immunoblasts are present. And in late stage, 4 to 8 weeks. So in late stage, number of small lymphocytes are predominantly increased, few large cells and scattered histiocytes and plasma cells may be present. Now background features, always look for lymphoglandular bodies, some scattered histiocytes may be present, and plasma cells or plasmacytoid lymphocytes are present. Now immunophenotype, if we see, these cells are CD19, 20, 22, CD79A B cell positive, few BCL2 positive and CD10 cells are present. Kappa and lambda ratio is generally 3 to 5:1, and T cells positivity is shown by CD3, 5, 4 and 8. Histiocytes are positive for CD68 and follicular dendritic cells are CD21. So here along with this high Ki67. So here these are the kappa chain stain with this immunoperoxidase stain. These are the lambda. CD3 positivity is also seen and high Ki67 is seen here in the smear. And if we do for go for cytogenetics, so here no BCL2 rearrangement is seen because it is mostly in the follicular lymphoma. So it helps differentiate it from follicular lymphoma. And what is the pitfalls? Important pitfalls are: be cautious because in elderly patient, reactive changes are less likely. There is a histiocytic response in the lymph node near malignancy even though lymph nodes are not involved. And sometimes Hodgkin's lymphoma may show reactive background. So these are the important pitfalls we have to look for. Now this is the table showing difference between reactive lymphoid hyperplasia and follicular lymphoma type 2. So in reactive, most common in children, then adult, and very less likely in elderly patient. And cytologically, lymphohistiocyte aggregates are present. Pseudolymphohistiocyte aggregates, which is absent, present in follicular lymphoma. Centrocytes and centroblasts are variable in number in hyperplasia. Atypia absent or mild, mitosis present. Small round lymphocytes, immunoblasts, plasma cells, tingible body macrophages are present. Eosinophil may be present. And markers, if we see in lymphoid hyperplasia, both kappa and lambda light chain is present, BCL2, BCL6 negative, CD10 negative, and Ki67 shows high proliferation. While in follicular lymphoma type 2, it is rare in children. Though lymphohistiocytic aggregates are absent, pseudolymphohistiocytic aggregates are present, which is a mainly form of centroblastic cell and centrocytic cells, and without tingible body macrophages and follicular dendritic cells. So these are, and here centrocytes are more in number than centroblast. Cytologically atypia present, mitosis which is rare, and immunoblast, plasma cell, tingible body, and eosinophils are rarely present or absent. In markers, there is monotypic, either kappa or lambda chain is present, not both chain are present. BCL2, BCL6 positive, CD10 positive, and Ki67 shows low proliferation. Now second, early human HIV lymphadenitis. So here it is caused by RNA virus. It target immune system, mainly CD4 T cells. In acute phase, patient present with fever, flu-like illness, and generalized lymphadenopathy. Duration may be for few weeks, and chronic phase suggested by persistent lymphadenopathy and may last for years. And now cytologically, acute phase, which is showing reactive lymphoid hyperplasia pattern, numerous tingible body macrophages, high mitotic activity, and predominantly intermediate and large lymphocytes are present, but few small lymphocytes are present. And additionally, there are monocytoid cells like multinucleated giant cells, which is also known as grape-like clustered nuclei, or neutrophil may be present. So, study showed that if lymph node aspirated from HIV positive patient is there are increased number of immunoblasts than those from HIV negative patient. So here we can see in this smear there are increased number of transformed lymphocytes, and these are the immunoblast increase in number. So this is immunoblast, largest size in this smear and having dark blue rim of cytoplasm and prominent nucleoli. If chronic phase aspirate is there, there is decreased follicular hyperplasia and increased plasma cells. Along with mixed lymphoid population is seen, and in late or burnout phase, stromal fragments are present, which shows endothelial cells and fibrous tissue, and decreased lymphocytes and plasma cells. Immunophenotypically, mixed population of B cell and T cell is present, no monoclonality, which is of follicular lymphoma, and multinucleated cells show CD21 positivity and CD35 positivity, which is suggestive of dendritic cell origin. So, key diagnostic features: polymorphous population, large lymphoid cell predominance, tingible body macrophages, high mitosis, and no light chain restriction. And differential diagnosis, mostly we have to look for follicular lymphoma and also similar patterns seen in cytomegalovirus, Epstein-Barr virus infection, and other virus infection like measles and varicella. So, for that we require serology for confirmation. Now, key pitfalls in this type of lymphadenopathy is that acute phase mimic lymphoma and overdiagnosis risk is there. So, always correlate clinically and use ancillary test. And clinical significance of this type of HIV lymphadenopathy is there. There is increased risk of non-Hodgkin's lymphoma, and if patient having AIDS or having antiretroviral therapy. So, what is the take home message for this lymphadenopathy? HIV lymphadenitis show polymorphous pattern, acute phase show high mitosis and large cells, chronic phase shows plasma cell, and always differentiate from lymphoma. Serology and clinical correlation is required. Now, third is primary and secondary syphilis lymphadenitis. So, here etiology is the spirochete organism named Trypanosoma pallidum, which is 5 to 15 mm long and less than 1 mm thick. Transmission is by sexual contact and vertical from mother to fetus. Clinical feature include in primary syphilis is regional lymphadenopathy and chancre, which may last up to 4 weeks, and secondary syphilis where generalized lymphadenopathy, rash, mucosal lesions, and condylometallata, which may last up to 2 years. Here the nodes are large form and painless. Here cytologically there is florid follicular hypoplasia where small lymphocytes and scattered immunoblasts, but key feature is numerous plasma cell and occasionally non-caseating granulomas seen. So, whenever you see plasma cell rich polymorphous pattern, think syphilis. So, here in this touch imprint of lymph node shows multiple plasma cells in the smear. So, here you can identify increased amount of plasma cells. So, confirmatory test is with the help of dark field microscopy where spirochete organism can be identified. We can take help of immunofluorescence, or Warthin starry stain can show this type of organism. PCR serology like VDRL and RPR test or TPHA test, and fluorescent trypanomal antibody absorption test can be helpful. Differential diagnosis include first is reactive, then HIV lymphadenitis, some chronic infection or early lymphoma. So, plasma cells are very important, and nodes are here painless but firm and always correlate with clinical findings. Cytology alone is not confirmatory. Now, fourth is toxoplasma lymphadenitis. It is caused by Toxoplasma gondii. Transmission by cat feces, contaminated food, transplacental or transplantation. Clinical features include posterior cervical lymphadenopathy, and here the nodes are firm, variable size, tender, or may be painless. May persist for months, and immunocompromised status may lead to disseminated disease and which is severe or fatal. Cytologically, core features include polymorphous population, plasma cells, tingible body macrophage immunoblast, but identification organism which is helpful clue is crescent shaped trophozoites, tissue cyst. It is rare but diagnostic if present. Additional clue include there is presence of monocytoid cells, epithelioid cells, small aggregates and microgranulomas. Here the negative diagnostic clue include here there is no necrosis, no giant cells, which is important to for differentiation from tuberculosis. So whenever posterior cervical lymph node microgranuloma without necrosis, toxoplasma until proven otherwise, and this type of crescent shape tachyzoids are present extracellularly as well as intracellularly. These are the toxoplasma gondii tachyzoids. So differential diagnosis, all the lymphoid hypoplasia, reactive, tuberculous, sarcoidosis or viral, it is confirmed by serology, IgM, IgG and PCR if organisms are not seen. Now, Leishmania lymphadenitis. So, Leishmania, it is caused by Leishmania donovani and Leishmania infantum. Transmission by sandfly, which is phlebotomous. Clinical features include regional lymphadenopathy. Nodes are moderately enlarged, firm, mobile, non-tender, and it is also seen with visceral leishmaniasis along with the cutaneous leishmaniasis. So, cytologically, polymorphous population, plasma cell and tingible bodies are there, but additional features are giant cells, necrosis may be present, atypical plasma cells present in immunosuppressant patients, and diagnostic most important features is LD bodies, that is Leishmania Donovan bodies. They are small round oval organisms intracellularly within macrophages, also free in background, and a rose-shaped kinetoplast is seen. So here we can see this is a promastigote stage and this is the amastigote stage. So here we can see nucleus, this is kinetoplast, basal body and exonym, and in this form we can see flagellum. So microscopically in this Dipquick smear we can see this is the cell showing intracellularly these are tiny LD bodies. This is intracellularly, this is extracellularly. So these are the macrophages intracellularly containing this amastigote form, and here dot like is kinetoplast and this is nucleus. This is another picture, you can identify two dot like appearance, small is kinetoplast, this is kinetoplast and this is nucleus. So two dot appearance is important. Now differential diagnosis include reactive lymphoid hypoplasia, toxoplasma, tuberculosis, other infection, but confirmation and diagnostic is with the demonstration of LD bodies, and if required PCR is needed. So intracellular organism with kinetoplast, which is leishmaniasis. Now rheumatoid arthritis, it is autoimmune disorder associated with HLA DR1 DR4, clinically commonly seen in female 35 to 50 year age, symmetrical small joint involvement, hands and feet, painful swelling, lymphadenopathy mostly cervical, then axillary and supraclavicular, and seen in more than 50% of patients. Core pattern, as the name suggests, polymorphous, but prominent plasma cells are there, immunoblasts and tingible body macrophages is there. Additionally, we can see neutrophils, sometimes small granuloma and necrosis, and it reflects follicular hypoplasia as well as interfollicular plasmacytosis. So whenever we find plasma cell, first is syphilis. Along with the clinical history of joint pain and joint swelling, plasma cells are there, always suspect for rheumatoid arthritis. Immunophenotypically, it is polyclonal population, no light chain restriction, and both the PAN-B and PAN-T markers are positive. Differential, as we have discussed, all the polymorphous pattern lesion. Now, clinically, diagnostically, we have to see for history of rheumatoid arthritis and joint symptoms. Plasma cells are prominent, and sometimes there is risk of Hodgkin's lymphoma and non-Hodgkin's lymphoma. So, we have to look carefully whenever this type of symptoms along with the plasma cells and rheumatoid arthritis history is there. We have to rule out all these features. Now, Castleman disease. It is non-neoplastic lymphoproliferative disorder having two types. One is unicentric, second is multicentric, and two types: morphologically hyaline vascular type, which is most common, plasma cell type, and mixed type. Clinically, cervical and mediastinal lymphadenopathy is there. Plasma cell variant shows fever, weight loss, anemia, and multicentric shows systemic disease. Core pattern where polymorphous lymphoid cell population along with the small lymphocytes, follicular dendritic cells, and vascular fragments. Scattered lymphohistiocytic aggregates, tangible body macrophages, small number of immunoblasts are also present, and staining for HHV or herpes virus 8 supports the diagnosis. Plasma cell variant, as the name suggests, key feature numerous plasma cells. It mimics reactive condition and chronic infection. In hyaline vascular features, there is hyalinized vessels increase in amount, and follicular dendritic cell fragments are seen. So, here we can see cytologically some small lymphoid aggregates are seen in 4x view. Here in high power view we can see lymphoid aggregates, but these are the traversing capillaries or vessels prominently seen here, and these are the follicular dendritic cells predominantly seen with these dispersed lymphocytes, and here we can see prominent follicular dendritic cells with emperipoiesis. In this histological section, this lesion having lollipop sign where there is atrophic germinal center and this expanded mantle zone, and which is penetrated by this sclerotic blood vessels. So, we can see this is the sclerotic blood vessels, atrophic germinal center and expansion of mantle zone. So, this is called lollipop sign. Differential diagnosis: all the lesions of polymorphous pattern, and immunophenotypically it is polyclonal and no light chain restriction which support the diagnosis. Now, Kimura lymphadenopathy, unknown etiology and associated with chronic inflammatory disorder, most common in young Asian males. Head and neck region, mostly retroauricular and salivary glands are affected. Lymph nodes are enlarged and confluent. Confluent means they are merged together and making a large mass. Laboratory findings show important is eosinophilia. So, peripheral eosinophilia means increased eosinophilic count in CBC and serum Ig is increased. Cytologically, polymorphous lymphoid population, hyperplasia, follicular hyperplasia, plasma cells, but key diagnostic feature is numerous eosinophils and presence of mast cells. Additionally, sometimes we can find collagen fragments, fibrovascular stroma, and multinucleated giant cells known as Warthin-Finkledy cell or graphene-like nuclei, which is also known as polykaryocytes. And immunophenotypically, IgE positive dendritic cell is seen. So, this is multinucleated polykaryocyte, which is also known as Warthin-Finkledy cell, and background show polymorphous lymphoid population. So in this histosection also we can see this type of multinucleated cell. So these types of cells are also seen in Hodgkin's lymphoma. So how to differentiate? With the help of eosinophilia, IgE is increased in Kimura, RS cells are absent and clinically it is benign and chronic, while Hodgkin's lymphoma show eosinophil present but not prominent, normal IgE level and presence of Reed-Sternberg cells. Differential diagnosis, all the entity of polymorphous pattern. Now, early stages of dermatopathic lymphadenopathy. So, by definition, this is reactive lymphadenopathy associated with skin disorders, can be seen in benign skin disease as well as cutaneous lymphomas. Most common affected lymph node group are axillary and inguinal, but may be generalized, associated with chronic skin disease and pruritic dermatosis. Here the core pattern is polymorphous, but lymphohistiocytic aggregates are immunoblasts, plasma cells and eosinophils are present. Key diagnostic features include pigment-laden histiocytes, either lipid-laden, hemosiderin-laden or important is melanin-laden. And additionally, interfollicular dendritic cells, background pigment and there is follicular hypoplasia is present. So here in this Pap stain smear, we can see this melanin-laden histiocytes which is surrounded by mature lymphocytes and some cerebriform lymphocytes. So this is a slide of Cesare syndrome which we'll discuss in next slide. Here also you can see in this section multiple melanin containing histiocytes which is the suggestive of dermatopathic lymphadenopathy. In the early stage, there is follicular hyperplasia and in late stage, there is paracortical expansion and immunoblastic proliferation. And differential diagnosis include all the polymorphous pattern lesion. How to differentiate from Kimura? So here pigmented histiocytes are present, here absent. Mark eosinophils in Kimura and Ig increased. And here skin disease are present in dermatopathic where Kimura not essentially required. Now Sézary syndrome which is cutaneous T-cell lymphoma, it is leukemic variant of mycosis fungoides and systemic involvement is there. Clinically generalized lymphadenopathy, erythroderma, peripheral blood involvement and eosinophilia is present. Cytologically scattered monomorphic lymphoid cells which is small to intermediate size and key diagnostic is cerebriform nuclei means brain-like fold or in the nucleus of cell and background shows dermatopathic pattern and melanin-laden histiocytes. So here you can see this is the imprint slide from lymph node where this is the cerebriform or brain-like folding nuclei are present in this smear and this is the histosection where you can find this increased number of cells having this folded nuclei or cerebriform nuclei. So whenever you find cerebriform lymphocytes plus erythroderma, always suspect Sézary syndrome. And differential diagnosis include dermatopathic lymphadenopathy, reactive and other T-cell lymphoma. Then early cat scratch lymphadenitis. So etiology is caused by bacteria named Bartonella hensleyi. Clinically, history of cat scratch present regional lymphadenopathy and tender lymph node is the sign. Early cytology is polymorphous pattern along with key necrosis pattern is triad, necrosis, granuloma and neutrophils. So, it is suppurative granulomatous lymphadenitis where you can find this is the granuloma with necrosis and in center in abundant amount of neutrophils are present. So, differential diagnosis include tuberculosis where neutrophils are absent, toxoplasma and reactive lymphadenopathy. Here this is Warthin stain where we can find this extracellular cocobacillary gram-negative bacteria which is Bartonella hensleyi, and whenever granuloma, neutrophil, cat exposure, suspect cat stress disease. Now these are all the features, all the lesions we have discussed are of non-malignant. Now some malignant like follicular lymphoma grade 2 also show polymorphous lymphoid population. So it is very important to rule out lymphoma in rare cases. So by definition it is most common non-Hodgkin's lymphoma, mostly seen in western countries, germinal center and B cell origin, and histologically there is nodular architecture. Clinically, adults are more commonly affected, rare in children. Cervical and inguinal nodes are affected and having soft or rubbery appearance. Generalized lymphadenopathy is seen and B symptoms are seen in nearly 20% patients. Core pattern showing high cellularity, most commonly dimorphous or polymorphous pattern. Means centrocytes and centroblasts are predominant. Centrocytes are identified by cleaved nuclei and centroblast which is non-cleaved, large and prominent nucleoli, and there is uniform chromatin texture. And one of the important diagnostic clue is pseudo-lymphohistiocytic aggregate. So in true histiocytic aggregate there is presence of tingible body macrophages, but here in pseudo there is no tingible body macrophages, minimal reactive cells and no necrosis. So this is a case showing pseudo lymphocytic aggregate where these are the centrocytes and centroblasts are showing aggregate in smear. So here we can see this chromatin pattern which is similar in large as well as small cells. So these are all neoplastic cells having a similar nuclear pattern. So these are the neoplastic cells. Here also having a small aggregates of large and small irregular nuclear contour cells, and uh, very rarely you can find small lymphocytes. Increased number of centrocytes and centroblasts. Here also you can identify these are the large and small irregular and cleaved nuclei cell, and very small number of small lymphocytes can be seen. Immunophenotypically, CD19, 20, 22 and CD79 a positivity, CD10 which is germinal center marker is positive, BCL2 positive, and T cell markers like CD3, 523 and 43 are negative. Surface kappa or lambda light chain monoclonality is found. So either kappa or lambda, any one is found, and surface immunoglobulin M and G are less common. Cytogenetically, T1418 translocation BCL2 overexpression is present, suggestive of inhibiting apoptosis. Grading 1 is less than 6 centroblast per hyperpower field, grade 2 6 to 15 per hyperpower field, and grade 3 is more than 15 centroblast per hyperpower field. But there is limitation of accuracy on FNAC, so always go for histopathological correlation. So whenever we find cleaved nuclei, centrocytes, no tingible body macrophages, think for lymphoma, monoclonality is key, and FNA cannot assess architecture. So always go for histopathology, and differential diagnosis include all the polymorphous lesion we have already discussed. And whenever cleaved nuclei, no tangible body macrophages, BCL2 positive, it confirms follicular lymphoma. Now, Another is diffuse variant of follicular lymphoma, which was previously known as diffuse follicular center cell lymphoma, and it represents transformation of nodular follicular lymphoma, and rarely it may be present as primary diffuse lymphoma. Origin from germinal center B cells, again related to centrocytes and centroblasts, but here there is loss of nodular pattern and diffuse growth, which is seen in histopathology only. Clinically, adult patient, middle-aged and elderly are commonly presented with this lymphoma. Regional or generalized lymphadenopathy. Indolent course is there and better prognosis than follicular lymphoma in some cases. Cytologically, here small centrocytes or cleaved cells are present. Sometimes show mixed pattern showing both the centroblasts and centrocytes, and similarly morphologically follicular grade 2 lymphoma seen. Nuclear features as it is irregular cleaved nuclei, and chromatin is similar in small and large cells, and there is minimal reactive component. Mitosis increases as centroblast increases, and these tingible body macrophages are always absent, and there are no true lymphohistiocytic aggregate. So as the B lymphocytic lymphoma markers are positive, BCL6 positive, negative CD5 and 23, proliferative index Ki67 is lower than aggressive lymphoma, and BCL2 arrangement is less than 30%, which is less frequent than follicular lymphoma, and this translocation 14-18 may be present but less common than follicular lymphoma. So, follicular lymphoma showing nodular pattern, reactive hypoplasia, which is polymorphous and tingible body macrophages associated, marginal nodular marginal zone lymphoma CD10 negative, and this is CD5 and cyclin D1 positive Mantelsen lymphoma. So, key diagnostic clue is diffuse pattern, no nodule, cytologically follicular grade 2 lymphoma. CD10 shows germinal center origin, low BSCL2 rearrangement, and better prognosis in than classical follicular lymphoma, but transformation risk exists, and FNA has a limitation because it cannot assess architecture, so biopsy is needed. Now, nodal marginal zone B cell lymphoma, NMZL, which is rare indolent B cell lymphoma, which is 1.8% of non-Hodgkin's lymphoma. This primary nodal disease, no splenic or extranodal involvement is seen. It likely derived from marginal zone lympho B cells and possibly monocytoid B cells. So, it is suggestive of paracortical origin, and pathogenesis is heterogeneous, not well defined. Middle-aged to elderly persons are mainly involved, and presentation shows most commonly cervical, then axillary and inguinal in order. Abdominal nodes are in 50% cases, and B symptoms are present. Course is indolent, and it may transform to diffused large cell B cell lymphoma or DLBCL. So, cytologically either polymorphous or monomorphic. Background may show reactive hypoplasia, but or predominantly neoplastic population may be seen. So, key features whenever we find mixed population but monocytoid B cells, small lymphocytes and centrocyte-like cells, centroblast, immunoblast shows invariable component. There is plasmacytoid differentiation with or without plasma cells present, and pattern may mimic reactive hypoplasia. So, this is the smear showing nodal marginal zone B cell lymphoma where polymorphous population is seen, but you can identify increased number of these blastic cells are present. So, Architecturally, it can involve either marginal or perifollicular zone or follicular zone or sinusoidal, or it may completely efface lymph node architecture. So it is pattern is seen mainly in biopsy. Immunophenotypically, it is positive for CD19, 20, 22, 79 and BCL2, negative for T cell and CD10, 23 marker. Light chain mainly monoclonal, either kappa or lambda, and no specific hallmark abnormality in cytogenetically present but occasionally associated with trisomy 3, and rarely translocation 11, 18 is present, and 7q deletion may be seen. So, how you differentiate small cell lymphoma with the help of CD5 and CD3 positivity, mantle cell lymphoma differentiating with the cyclin D1 positivity, follicular lymphoma shows CD10 and BCL6 positivity, while reactive hyperplasia, which is polyclonal and tingible body macrophages, are present. So, nodal marginal zone lymphoma shows polymorphous population with monocytoid B cells, require immunophenotyping to exclude other small B cell lymphoma. And uh, all this which we have discussed for polymorphous cell pattern. So, key morphological clues that you have to remember is, first of all, always see pattern, see the clinical history, go for ancillary test and then diagnosis, and never rely on morphology alone, because here the features like tingible body macrophages present suggest reactive pattern, plasma cells infection or immune mediated, eosinophil is increased, kimura, microgranulomas suspect toxoplasmosis, necrosis granuloma neutrophil, cat scratch, monocytoid B cells, this nodular marginal zone lymphoma, cleaved nucleoli predominant follicular lymphoma, and melanin histiocytes suggest dermatopathic lymphadenopathy. And ancillary tests are mandatory in doubt because it helps us to rule out malignant to non-malignant lesion like monoclonality of kappa and lambda chain, IHC, serology and microbiology is helpful to rule out infectious lesions. So, to summarize, we have to think first what is the pattern, what are the clinical signs and symptoms, and then think for ancillary and test to go for diagnosis. So remember, polymorphous pattern usually means reactive, but never assume it must be proven. And always look for key clues like tingible body macrophages, plasma cells, absence of atypia, and in doubt, rely on ancillary test. So mastering this pattern will help you avoid one of the most critical pitfall in lymph node cytology, missing a lymphoma. So thank you, and keep observing, correlating and diagnosing with confidence. And yes, if you found this video helpful, please like, share and subscribe this channel for more such helpful videos.